I'm going to start explaining a little bit why we do the work that we do. I'm from Utrecht. We have a research lab working on implants. I'm going to show you a little bit of our work a little later into the talk. I'll have to interrupt because these are data that haven't been published yet, so I'll ask the audio-video guys to stop so you understand what that means. But I'd like to have the people that actually go through things explain to you what it means to be locked in.
Julia had suffered a stroke and was hemorrhaging at the base of her brain. She was rushed to a hospital where she had a second stroke. Doctors declared her incapable of seeing, hearing, or thinking. They said she would never recover.
People would come in and they would go to change her diaper. And they would say, okay, let's clean the vegetable up.
But Julia was no vegetable. She saw and heard and felt absolutely everything. But she was trapped, buried alive in a paralyzed body.
I try to lift my right hand, but it's rigid, inflexible. I struggle to move my feet and can't. I try to scream to convince myself I'm alive. No sound comes forth. I think, this is what death must feel like.
Julia desperately struggled to communicate.
She tried crying. She tried moving her eyes. She tried, at some points, she said that she tried throwing up at will, just to get them to look in her face. And then she could maybe use her eyes to somehow make them know that she was in there.
Julia tried everything, but nothing worked, except for one moment of raw, honest emotion. It happened the day her husband, George, arrived wearing a black suit.
He told Julie that my father had passed away, and she started to cry. And so he went running out to the nurses and the aides and anybody he could find on the floor and said, listen, I just told her that my brother died and she cried. Doesn't that mean something? And they said, no, she cries all the time. Just go home. She'll never be any better.
Weeks turned into months and months into years. She was there, but no one noticed. She finally realized that no one would ever notice. For 6 agonizing years, Julia lay entombed. But then, one miraculous day, speech therapist Arlene Kratt wandered into her room.
I don't remember everything that happened in that evaluation, but the part that sticks out in my memory the most is I remember saying to her, look up, and then she did. And I said, now look up twice, and she did.
In the past 6 years, no one had thought to ask me these simple questions.
So that's locked in state. She wrote a book. If you're interested, it's definitely a good read. So what is a locked in syndrome? It's a syndrome where you have no control over your muscles. If you sit down and imagine a little bit, you will also become aware that you have no way of expressing your wishes or your thoughts, that you have no way to engender any communication. You're not able to speak, typically minimal communication. People can move their eyes, like you just saw in a movie. Cognition is intact, so that's why it's called locked in, because your mental capabilities are fine. The most frequent cause of this is stroke. Stroke of the brainstem that will disconnect all the connections between the body and the muscles. Trauma, and also neuromotor disease. And ALS, in our work, we increasingly work with ALS patients, and there's another movie I want you to watch.
I've been so terrified of ALS my entire life because it runs in my family. ALS runs in my family. My grandmother had it. She was a second mother to me. My mother was diagnosed when I was in high school, and 5 months ago, I was diagnosed at 26 years old. ALS is so fucking scary, you have no idea. I hate talking about it. I really hate talking about it. And that's probably why nobody talks about it, is because it's so challenging to watch. It's so challenging to see and to talk about. Nobody wants to see a depressing person that's dying, that has 2 to 5 years to live. They don't want to talk about it. They don't want their day ruined.
So what's ALS? It's a motor neuron disease. It's one of the fastest and one of the most well-known. I think everybody's heard of the Ice Bucket Challenge, which was a very successful way of getting people's attention to this. It's a disease that you won't run into very easily because people pass away very fast. The prognosis is 3 to 4 years. In essence, there's some cases that are much longer, but that's unpredictable. Like Steve Hawking is a case. There's no cure. There's nothing you can do about this except for wait and see how it progresses. 4 in about 100,000 people have ALS. And because you lose all controls over muscles, you are certain at the age of 26, Anthony, he's certain he will end up in locked-in state if he decides to live that long. The way of communication is very fundamental. I've heard about it many times, and until you see it, you realize what it is to communicate that way. This is the most reliable way of communicating. It works.
From how she was from when she first come in to how she is now, she has progressed quite a lot. I wish it was more, but it's not so. But we're impressed with you, aren't we? She'll just wish that she can just recover straight away, don't you? Just snap out of it. Burst out of your own body, eh?
The only way Michelle can make herself understood is by using eye movements. Raising her eyes means yes, and looking down means no.
It's pretty easy because knowing her, I know what she'd be thinking, and I know what she'd want or how she'd feel about certain things. But with having the communication aid, spelling, it can be hard sometimes, spelling stuff out to us, but at least she can get a point across. She can tell me what she wants to do, what she wants me to do with the kids. A, B, C, C, red, blue, green, orange, purple, U, C, U, red, blue, green, orange, P, Q, R, R. C-U-R, is it curry? Yeah, curry. We want you home, don't we? You got to get out of here and get home. I know it's going to take time, but just to get her home, see her kids grow up, be involved more with them, and just try and get life as normal as it can and back to how it was. I know it is going to be different, but just to get it as best as we can, to be honest.
And if you could sum up watching Michelle and how impressed you've been with how she's coped with what happened, how could you do that?
To say how I'd feel what she's done is amazing. I couldn't have done it anyway, no way. Could I? No. She just won't give up with anything. She's never been like that. Never have you? She'll get there, I know she will. You do, don't you?
James Webster, Channel M Today.
So, it's a little hard to understand. It's original English, but one of the things that's clear is that she wants to stay alive because she has kids and she wants to make an impact. She wants to deal with the children. So the quality of life in locked-in state has been moderately investigated. There's one particular study I very much appreciate by Bruno in 2012, where they asked people who were in a locked-in state about their quality of life, and the ratings were almost as high as what you and I would rate on a scale of 1 to 10. Another finding was that the people who take care of locked-in people, and especially the medical profession, has a much lower indication or impression of quality of life. So there's a bit of a mismatch. So the thing is, it's not automatically a low quality of life. People choose to stay alive, and that's where my story comes in. So the key factors in this quality of life are social interaction, family, those are the most important things, communication, and any degree of independence, anything that will allow a person to have a private conversation or private communication with someone else rather than have to go through, as you just saw in the last movie, always go through someone who is willing to take out the letter card and spell it for you. End-of-life decisions for ALS. If you don't do anything, your respiration muscles will stop working, you will pass away, and it's not a horrible way to pass away. And most people choose for this because they fear of what comes after. The burden of family is a big matter. It's a very big aspect in the ethical debate about what to recommend to people on ALS, whether or not to take a mechanical ventilation system. It's a big step. Fear of locked-in state is definitely at the forefront. And there is also fear of cognitive impairment. What if you're locked in and you don't even function well? So there's differences, huge differences between countries in how they deal with this important question in life. That is the mechanical ventilation. It's a little bit of a surgery. You get a tube and the machine will make sure that your ventilation is intact. If you do that, you'll stay alive another 5 to 7 years. It typically depends on small things, infections, pneumonia, things like that. But this is what you can expect. And if you're healthy, it could be even longer. The rates, they differ quite a lot. Japan has a very high rate of people that choose to have a tracheostoma. And if you look in England, it's one of the lowest. The number I saw is 0%, which means that none of the patients take or get the option to get a tracheostoma. But the point is, across the world, there's a lot of people that are in a state where they know they'll get locked in. They have chosen to stay alive. So what does it take to prevent locked-in state? We can't do anything about the disease. There's no illusion there. But can we do anything about what happens to them if they choose to stay alive because they want to participate in their family life? Usually they have children or grandchildren they want to work with. You have to have a system, no matter what system. That's always available. You can depend on your caregiver, but it's much, much, much better if you have a system that you can use, like I can use anytime I want. I can use my voice, and time I want, I can click a switch or something. They don't have muscle control. It needs to be very reliable. I think John pointed out yesterday very nicely how important it is to have a reliable system, and that's the work that starts after the lab. In lab, you have the proof of concept, the 80-20 rule. And once you want to make it work for people, you suddenly have a huge challenge to make it reliable enough for those people to actually use it and have pleasure in using it. The effort should be minimal. You can't be completely tired after half an hour of using a system. It ideally is autonomous, that you do not depend on the skill or the presence of a caregiver. Aesthetics are definitely an important aspect. If you have a big cap with the electrodes on your head, that typically is not regarded as very charming, and it might even be experienced as stigmatizing. Affordability, of course, is an obvious reason. So what do we have for locked-in state now? Basically two. The letterboard that you just saw, which is by far the most widely used because it's a piece of paper, a piece of plastic, and most people can figure out how to use it. And the eye tracker has gained a lot of ground, I think, in the last 10 years. There's a fair number of people that can actually use an eye tracker where you look at a screen and you focus on one particular icon and you dwell on it for a few seconds, it will select that. Other than that, there's not much around. So there's BCI. And I was going to give a little bit of an introduction, but if you look at the three most commonly used BCI, EEG-based BCI techniques, and EEG is the only one that's portable enough. Maybe there's some NIRS nowadays coming in, but it's too early. It's SMR, so sensory motor rhythm, which is the mu or the beta, decline when you try to move, the steady state visually evoked potential, of which you saw a little bit yesterday by Donchen. But the P300 is the only one I have a slide of, because the first two, they're not really used in people who are paralyzed to any degree. It's minimal. The P300 has had an enormous amount of work put into it, not the least by John Wolpaw's work with Theresa Vaughan and Eric Sellers, and Andrea Kubler has done some work on this. But they're small studies because it's an incredible amount of work to do this with these people. So basically, if you squint your eyes, so it's the EEG with flashing icons. I'm not going to show you how it works. I assume most of you know how it works. It's 8 electrodes or so on the parietal visual cortex. You measure the evoked potential. The brain response reveals which letter you're looking at. Like healthy controls, who everything is intact, you get roughly performances of 91% correct if we say spelling mistakes or something. In patients, it's already a bit lower. They tend to make more mistakes for whatever reason. And if you actually look at patients, how well they perform in a larger population, there was a study by Mack. That's the last name anyway. It's 50% good performance, but it doesn't work for everyone, and in a bunch of people it doesn't work very well. So you're not quite there yet. If you put it in a graph, I try to pick out the most important features. I'll let you absorb this a little bit, because I'll come back to this at the end of the talk. So this is the eye tracking, the most, I think the most effective way of allowing people to communicate. It's not always available. It needs to be set up. It needs to be calibrated. It's definitely very reliable. Effort is pretty minimal. People can use it for hours on end. Independence is limited because you need someone to set it up. And aesthetic is very pleasant. There's nothing that's attached to the body of the user. And it's fairly affordable. It will cost you a couple of €1,000 per year, a couple of $1,000 per year or so. But for all the BCI based, it's not always available. There's a lot of minuses in there because it's just not quite good enough. The P300 again is the most promising, but it's still struggling in the independence, the reliability, and some degree the effort. So there's a clear need for better BCI. I think most of the people that I just mentioned that do this work will agree with me that it's just not good enough yet. So how about an implant? In principle, it's a much better signal. You're under the skull. It's you have less blurring of your signal, less interference and confounds. It's always available because you put it in your implant there for a purpose. And it's aesthetic because if you do it right, you can't see anything on the outside.